I am a heart and lung surgeon at the Bangkok Heart Hospital, Bangkok, Thailand. Okay. Sorry, my slide is a little bit. This is my disclosure slide. As a disclaimer, I have no financial relationship with any commercial interest related to the content of this activity. The objective of this talk are to develop the practical knowledge and skill on basic healthcare and to promote active and health lifestyles for all participants and to create awareness of the cause and effect of some health hazards to provide useful medical consultation. And I will give you the evidence base of medicine scientifically. You can see now here, this is a viral particle, okay? Complete viral particle have protein, the S proteins or spike, okay? This is the target for the vaccine to produce antibody, and M is membrane, N is nucleocapsid, and single strand RNA, okay? And this is envelope. When the viral particle attached to our cell, the blue is our cell, okay? So the virus attached to our cell through the spike protein and receptor in host is angiotensin converting enzyme 2, okay? And it go to the our cell and it's replicate, make more RNA and develop to complete particle of virus into our blood circulation, okay? And the replication cycle take about 10 hours. Observing evolutionary change in the gene require looking across at least 10 to 100 of generation. So the evolution of the virus can take about day to up to weeks. Okay, so viral can mutate and change their protein, and some days will survive, like Omicron. And we now go to Omicron, and we still have another night to go. I hope we not use all of them. And this is the wave of the COVID-19 in South Africa. So after the peak in each wave, okay, it takes about 5 months to 6 months to have another wave, or they change the viral particle, change from beta to delta and now Omicron. So the first Omicron is reported in this town, okay, near Johannesburg in South Africa, okay, and the WHO announced it a variant of concern. Oops. What happening? Huh? ทำไมฮะ
การใช้สปินใหม่สไลด์
Sorry about that. So when the Omicron come in November, okay, November 25th, and it takes only 2 weeks to become a dominant variant in South Africa. Only 2 weeks. It's very quick. Normally it takes many months, and now for Omicron it takes only 2 weeks to become dominant, and then it's starting decline. Maybe because of natural immunity combined with the vaccine immunity. So it's a hybrid cell-mediated immunity between vaccination and natural infection, and it brings the curve down. Okay. And for unvaccinated participants in this study, they have found the antibody anti-spike and also anti-nucleocapsid immunoglobulin G, and it's positive about 70% of these participants. And you can see from this, the transmission of Omicron is very fast, faster than Alpha, Beta, and Delta. So it goes very quick. So we have to be very careful with this. And after from Africa, it's go to UK, okay? It's spread to UK and USA, to Australia and Europe, and then now it's coming to Asia. And we have a lot of Omicron in Thailand and also Singapore, Hong Kong, and Malaysia now. Okay, you can see the curve from South Africa. Is the peak is not very high, but in Canada, UK, and USA is very high. This is case per million of population. And now on the 3rd of March, Korea is getting more than Singapore now. And if you plot Hong Kong is here now. So it spread very quick in 1 week. And Thailand curve is going upward trend. Okay. And I think the Australia is coming down now too. But all Asian countries start going up this week. This is Mongolia, Indonesia, Myanmar, and Philippines. Maybe they are under report and things. And because of the Omicron, the mutation in spike protein is very high, so they got a new name as Omicron variants. The other haven't got any new name if it's not highly mutated. So what about viral dynamic of Omicron? You can see from this slide. Some of you may got the test, like you can see the CT. CT is the cycle threshold. On the left side, the scale is at the bottom is high number, okay? But scale on the right side, the higher number is on the top, okay? So if the Omicron have a 23 cycle threshold, that means the viral, the number of viral RNA is not very high because CT number is high, okay? But the Delta, in contrast, the CT number is low, then the viral RNA is high, okay? You follow me? Okay? But the proliferation time is the time from the patient have viral until its peak. It's about 4.5 days. It's the same as between the Omicron and Delta is the same. And this is the current time. It means the time that the viral peak until it's go away. Okay, it take about 5 days for the Omicron and 6 days for the Delta variants. And this is another paper you can see here. The unvaccinated people, okay, when you compare Delta and wild type is Alpha and those original variants, okay, the number of infectious viral loads is higher for the Delta. That means what Delta is more productive than the other old or original variants, okay? But after you have vaccine, the vaccine bring the viral load down, okay? Compared to unvaccinated patient, okay? But when you compare the Omicron with the Delta, it's not different. Even though the Omicron, the viral loss is lower, but it's not different, significant different from the Delta variants. And this, I just want to show you the real people, the real patient from one hospital in California, USA, okay? So in this group, they have 1,000 patients admitted to the hospital, okay? And we cannot really compare between Delta and Omicron, but you can see unvaccinated patients have admission to the hospital about 56%, okay? And fully vaccinated still have to be admitted. That means if you have a vaccine, you can still get infection about 40% and sick enough to be admitted into the hospital. And you see this in the hospital, about 17% of patients with Omicron have to be admitted in ICU. That means it's very not all of them are my case. 15% to 19% is severe enough to be admitted, and it's not good because when they admit, they have some patients have to stay with the mechanical ventilation. They have to put the tube in the throat and you put on the machine to help them breathing. That's not very good. And about 3.4% of patients die with Omicron in this hospital in California. And overall, it's about 4%. For the Delta, it's about 8 or 10 in unvaccinated and fully vaccinated. If you fully vaccinated, you still can die about 3.4%. And from the paper, we can conclude that the COVID vaccine associated with lower likelihood ICU admission, but I think it's still significant number of patients go to ICU and have to put on machine for breathing. And also the mortality rate is a little bit concern for us, okay? But the booster dose will minimize the risk of severe disease. This is, I think, is much better data, okay, from Ontario, Canada. They have Delta cohort and Omicron cohort, 24,000 and 37,000. They match the group. So the match cohort is here. So both group have the same age, sex distribution, vaccine, okay, injection, and they can compare between two groups because they match. So it can be compared, and we can see that. Oh, sorry. The hospitalization for Omicron is about 0.6, okay, and the mortality is 0.03%, okay. So it's different because maybe it's different country and different resource, and the number of patients is different. If you have much more patient in the hospital, maybe the resource is not enough, or if it's tertiary hospital, the patient is very sick, so the chance that you die from Omicron is between 0.03 to about 3%, I think. So how about the children? Okay, the children under 18, okay. So now we have the vaccination for the kid over 8 year old, okay, over 5 year old, but over younger than 5 still have some problem, okay. Maybe 40% of patient 40% of patient are younger than the age that they give vaccine, so that may be a problem. And it can be severe too. About 40% of patients that have multi-system inflammatory syndrome in children is younger than 5. So this group is very concerned. So we might have to give vaccine for these children also in the future. And because of this, it's a Delta period of variant. But now we have Omicron, and Omicron is infect, and the incident in the child is younger and younger. So it's not the same as Delta that have more people in older age group. Okay. And this I want to show you that the patient have vaccine can still have infection, okay, for Omicron and Delta. You, some virus can escape the immune system. And for the kid also same as adults. Um, over 60% they have some medical problem like obesity in children, have more prevalent, more incident of COVID infection than the normal kid. And they do sick enough to be admitted in ICU, about 19 to 25 to 40%. It depends on age group, okay? So the age group between 12 to 17, and they admit in ICU about 40%, okay? And it varies between 20 to 40. And they can die from COVID too, between 1.5 to 2.9%. And the conclusion is that among the children and adolescents with COVID-19 infection admitted in 6 hospitals, about 80% hospitalized with the COVID, because sometimes I think it's difficult to make them stay home and watch them at home for the kid. And about 1/3 age less than 5 have approximate 2/3 got another virus superimposed, okay, co-infection, okay, and 2/3 of the patient with uh, age between 12 to 17 have obesity. And what about the vaccine induced myocarditis? Okay, vaccine induced myocarditis is being reported, and this is uh, result from the vaccine adverse event report system from USA. Okay, so in US they have system for record the adverse event from the vaccine, same as UK and every country. I think they may have some kind of system to get report from the community and general population. Okay, and at this time, the Pfizer vaccine is for people over 12, and Moderna is for over and 18 years. Okay. And I think the incidence of myocarditis or heart muscle inflammation from the vaccine. Okay. Myocardium is the heart muscle. Ditis is the inflammation. Myocarditis is heart muscle inflammation from the vaccine, and pericarditis is heart sac inflammation. Okay, its incidence is about 1 in 200,000, so it's not very high. And this is for different age group. It's for male and female. Okay, male have about after the first dose. This is incident per million. Okay, it's 4 to 7 per million dose after the first dose, and after the second dose, it's higher. Okay, 50 to 100 per million dose for the Pfizer vaccine. And on the right side, is for Moderna. The first dose is about 10 in a million, and the second dose is about 56 per million. Okay, for female kid is less. Okay, it's between 0.2 to 10, like something like that. And the median age for viral myocarditis is peak at the patient with 21 year old. Okay, and the incidence is about less than 18 is about 30%, less than 30 is 73%. So it's peak between peak at the age of 20 to 21, and 82% is happened after the second dose. Okay, and this slide I want to show you because if you get vaccine, you go and get Pfizer or Moderna vaccine, and you have this symptom like chest pain, that means your heart muscle it maybe have some effect from the vaccine. You have to go to see the doctor, okay, to get the treatment. Okay, chest pain or difficult breathing, or you have palpitation. Palpitation is not common. It's about 10% of the people have vaccine-induced heart muscle injury. Okay, so have to stay in the hospital 96% in this group, and about 10% have to go to admit in ICU. Okay, and nobody died from this side effect. Okay, from this paper, okay? And most of them can go back to normal, but it takes some time. And if you have vaccine, how many days that you need to observe for this side effect, okay? It's about 1 week, okay? But it can go extend to 10 days all over, but the incidence is less. The onset, it should be start at 2 to 3 days after injection. It depends on the first dose or second dose, but it's not much different 2 or 3 days after injection. If you have the symptom, you should go see doctor to get the treatment. Otherwise, you might go too late. Okay, too late, maybe not good. And we can see from this, you have the magnetic resonance imaging, okay, to see the heart inflammation, to be sure that you have heart muscle damage. For the kid less than 5 to 11, now we give the vaccine 5 to 11 years old as well. The incidence is, I think, is a little bit less than the older kid. It's about 2.3, 1.8 per million, okay, for male and female, okay. And this is a heart sac inflammation, pericarditis. It's about 2.3 for both male and female, or per million dose, okay? And I think for now, Omicron is not equal influenza. The death rate is different, okay? The death rate from influenza is 1.8 per 100,000, okay? But the Omicron is spread transmission is faster because the reproduction number is higher. The death is depend on where you live. It can be vary from 0.03 to 5% mortality. And you still have a chance to get the long COVID. It's different from influenza. And this, I want to show you, just emphasize that the viral COVID is go to your cell and it attached to your receptor in your host, your cell, ACE2, okay? And ACE2 is be a receptor for many organs, okay? The heart, the lung, the pancreas, okay? Intestine, okay? That's why the Omicron can cause many problems, but sometimes it's subclinical, you cannot detect it. But if you go to the lab, then you can detect some abnormal. And this is the long COVID. Even my case, like Omicron, most of Omicron is my disease, but you still have long COVID symptom. About 10 to 35% have long COVID after my disease. You have fatigue, difficult breathing, cough, chest pain, headache, and some brain problem. We still have to look for this long COVID symptom have to be observed in different variants. It may be different picture, okay? But it can happen. And the COVID-19 infection also associated with increased diabetes, okay? So if you have COVID vaccine, oh no, if you have COVID infection, about 31% more likely to have diabetes than the one that don't have COVID infection. In my opinion, I think universal precaution now is still needed, and contact tracing and isolation, it may be difficult now because it's so much many infected people in the community, so it's very hard to do the contact tracing and isolation. I think universal precaution, the masking, the mask, it helps you prevent the infection over 50%. So you need the universal precaution, social distancing, masking, and hand washing, and everything, okay? And do the vaccine. Vaccine now still have some benefit, even though it cannot eliminate the infection. It helps to reduce the death and severe disease still, okay? But we will need a new vaccine soon because the viral keep mutation. We have to keep develop our new vaccine. If we can get ahead of the virus, then we can stop the virus spreading. And also the medicine, immunotherapy, and the testing. Testing is also important, but I think it somehow it may be difficult to. And for the society, we need the digital transformation, new normal, and redesign the work and everything in healthcare and in also the business. And we need a global plan for the pandemic. We cannot do only one country to stop the viral infection. Singapore, you remember, the incidence of infection is very high now. Even they have 90% of vaccine, okay? 90% of the population have vaccine, but still got a lot of infection. Same Korea, 90% got vaccine, still have a lot of infection. Also, okay. Thailand now is only 70, 80% of patients have vaccine. But the world only 63%. So if we not vaccine our whole population in the world, somewhere it can be a new variant in the future. Somewhere in the world, okay? And then we start again. We start a next new wave again, okay? So this is, I still got time, so I want to give you this an article. This is interesting article that they do correlate the number neutralizing antibody, okay? Between neutralizing antibody and protection of infection. But this is for the wild type or original strain, original virus, okay? So what it means is if you have this number, you can prevent 50% of infection for the antibody, okay? So if the PRNT50 is in this gray zone, okay, it's good. Above this gray zone is good, okay? Below is not good, okay? So if you have Pfizer vaccine 2 dose, the antibody enough to prevent 50% of infection is not enough, okay? So antibody is not good enough for prevent the infection. If you have Pfizer 2 dose plus the booster dose, then the chance that you have antibody high enough is better. If you have CoronaVac. CoronaVac is the Sinovac, I think. Sinovac, Sinopharm, the Chinese vaccine. Even you got 2 doses, it's not enough to prevent an infection. Okay. If you got Sinovac 3 doses, the level of antibody is not enough. Okay. But if you have Sinovac 2 dose and you boost it with the Pfizer 1 dose, and you have a much better antibody level. Okay. And this is the one that have infection, and then they recover. We call this convalescence. Okay. The convalescent one have not enough to get prevention. Okay. So if you have COVID infection before and you contact the viral again, you can still get the reinfection. Okay. Because you have lower antibody. So if you have infection, the chance that you get infection again is very high. If you don't have any vaccine, okay? If you have vaccine, if you survive infection first time, you get Pfizer, the antibody enough to prevent another infection is higher, okay? This is about the same. But sometimes we test one antibody, but we don't test another side of immune response. So we have B cell and T cell. Okay. In this paper, they show you only the antibody side, but they not show you the T cell side. So sometimes T cell, if you don't have antibody enough, but your T cell response is better, then you can combat with the virus better. So this is part of solution, but not the all solution. And you can think about yourself. You want to get natural infection to get antibody, or you want to get the vaccine to get to make your body to produce immunity. Okay, we compare the two sides. Natural infection is you have a chance that you become very unwell, to admit in ICU and die. But for the vaccine, the chance that you die from the vaccine, I think it's very low. Side effect is for sure you have some minor side effect like pain and swelling, fatigue, fever. Those kind of things is, I think we can control it. So for vaccine, I think it's very safe and it's controlled way to get the immunity for your body. For natural infection, I think you take very high risk to become very sick, and sometimes you can die. And for the immunity itself, if you have natural infection, the chance that you have antibody high enough to combat another infection is very low because it's unpredictable. Some very mild disease, they don't have enough antibody to prevent the next one. But some patient very severe disease, you nearly die. You have antibody enough, but you already nearly die once. I think it's not good. Okay, but for the vaccine, you have more robust immune response. Okay, and the time too. After you have antibody, the antibody level is lower with the time. Okay, so if you after 3 months, 6 months, you have reduced your immunity, maybe cannot prevent another infection. Okay, but the vaccine, you can predict from the study, because they give vaccine, they follow up, and then if it's not enough, then they give a booster. Okay, and for the variants also, the vaccine can be made to the chain of the spike protein mutation, so they can make a new vaccine to combat this and make more antibody for specific variants. Thank you very much. Any question? I think we will keep the question after Professor Kim talk, okay? So next, I would like to ask Professor Kim to give his talk. We are very honored to have Professor Kim today in his busy time to give us a lecture. Professor Kim, please. Professor Kim is a professor of child health and vaccinology from London School of Hygiene and Tropical Medicine, UK. He is also a professor of Murdoch Children Research Institute and Department of Pediatrics, the University of Melbourne, Australia.
Thank you very much, Dr. Permyos, and thanks for your kind invitation and introduction. I think if you stop sharing the screen, I can share the screen.
Yes.
Just for everyone's information, I actually just came back a couple of days ago from Mongolia, and although their situation does seem to be relatively mild in terms of numbers, I can tell you from personal experience that most of the cases are not being counted. In fact, I think they've given up counting cases, and they're only really counting the severe cases and deaths. And I think that's probably true in many countries now. So the case numbers become quite difficult to follow. Can you see my slide now?
Yes, I can see and can hear very well.
Thank you very much. I'll turn my video off now, so in case there's a disturbance in the internet here, and just stick to myself. I set out to speak about the impact of the COVID pandemic on children and child health. And as I went along with this discussion, at least in my mind, I recognized that there are a number of things converging at the moment, factors that are converging all to the detriment of children in the world. And I see the world of 2022 and perhaps in the coming years as being rather a dangerous time for children, especially children living in impoverished or marginalized communities. So I want to address that more broadly and just think firstly about the background issues that are going on. And one of the obvious ones is climate change. It's a big issue here in Australia. Like, for sure, we are facing it head on, although our politicians have not yet realised that. But it affects different countries in different ways. But I would argue that in most parts of the world, it's actually children who are worst affected. But it's also children who are worst affected because it's their futures which are at stake. Now, this is the kind of image that we've seen in Australia for some of the things that have occurred that probably due to climate change, like this big storm in Sydney. And you can see that the people who are living on the waterfront in Sydney are by and large pretty wealthy people. The rich seem to gather in those places, but that's not the pattern in most parts of the world. And this typhoon in the Philippines highlights, firstly, the extraordinary damage that's done to people who are living in the coastal areas, but also the fact that the people themselves in those areas are generally the poorest and most marginalized people in that community. And of course, we have to then imagine what happens to children who were living in settings like this, not just during the typhoon, but in the years to follow that. In Timor-Leste last year, and this hardly hit the news even, there was also another major storm with over 90 people killed. And again, though, it's the most impoverished and vulnerable communities that suffer the most. And of course, the risk for children are extraordinary. And not just the risk of drowning or being injured, the risk of their family being driven into poverty and malnutrition, and then the long-term emotional stress and trauma, which I think many children are going to be feeling. So we are starting to get the idea that there will be many climate refugees. I put in inverted commas here because technically many of these people are not refugees, simply because they are often displaced within their own country. But these are mostly people who've gone from coastal communities which have become uninhabitable. But that's not the only group, as you'll see in a minute. And rural communities have tended to drift to the cities more and more under the influence of climate change. And these communities are going to form the basis of massive urban slums. And that is not just in tropical countries. The photograph on the right here is from Ulaanbaatar, where I've just returned from. And the photograph belies the extraordinary high rate of pollution in that city at the moment, especially in winter. Now, one of the problems in Mongolia has been a drift of people from the semi-nomadic existence that is their traditional lifestyle into the city. So a huge increase of people living in the city, very, very cold. So they have to burn something in their traditional tents that they live in, a ger, and they burn mostly coal. And most of that coal in the poorer communities is illegally mined coal of very low quality. So the smoke pollution is extraordinary. So that's the environment that many children in Mongolia are living in today. Accra is a city that I was in just at the beginning of the pandemic, actually. And Ghana is one of the better organized countries in Africa. But even in Accra, you find an extraordinary urban slum, which has increased enormously in recent years, and largely because of the increasing difficulty living in the remote areas because of climate change. So all these things are going on in the background, and this migration of people from the urban areas, from the rural areas into the city, is fundamentally bad for children's health. And it's often accompanied by a migration into poverty. There are obvious risk factors like crowding and malnutrition, lack of health care, and indeed air pollution, I've already mentioned. But the others are less obvious, and that is that children are living in families who have become very insecure, unstable. Parents are often depressed as a result, and the life of children becomes more and more difficult as a result of that. So this is the world for many people and many children in the present time. Sadly, in a lot of places in the world now, this problem is accentuated by political insecurity and war. Now, we often see children mentioned in the statistics for reporting from different war zones as innocent bystanders. Oh, some children were also injured or killed or something like that. But I would put it to you that there are actually weapons that seem to be designed as anti-personnel weapons, and those anti-personnel weapons are particularly lethal for children. And not only do they kill children in the acute phase, they often kill children in the years after the wars that are occurring. Now, the effect of war on children, though, I think has been made worse by the sort of the rather distant way that the war is conducted, so that the people who perpetrate the atrocities are often somehow insulated from the effects. And the movie Eye in the Sky was an example of that, with drones striking a war zone in Africa. But I would argue also that there are things going on at the moment which are particularly anti-child. And I've mentioned, well, I haven't mentioned collective punishment, but collective punishment has always been part of war. Unfortunately, we saw a lot of it in the Second World War. It continues today, especially in wars where there is long-standing ethnic animosity between ethnic groups. And collective punishment is punishment of children. They're the ones who suffer the most when communities are punished. And then there's the question of anti-civilian weapons. And you could give a whole lecture on this. It's extraordinary. I'm just going to speak about cluster bombs, but they're just one example. There are other nasty examples that are being used at the moment. This is the history of cluster bombs as far as I can gather. And you see all of the big arms manufacturers there have been making these things, US, UK, France, Russia, of course, and Israel. And the use of those, these are documented uses of these weapons on this slide. And I've tried as much as possible to point out where the actual weapons came from when they were used. Now, as you know, there has been a major international movement against some of these weapons, and there was a international law passed essentially outlawing cluster bombs. But they still continue, and this report from Syria 2019 just shows the extraordinary number of people who are being killed and maimed by cluster bombs today. The United States has actually banned them just a few months ago, incredibly, and that's certainly worth noting. But this information on the slide here about one of the types of cluster bombs produced in the US gives you an idea of what they do. 202 in the case of this particular make of them. Bomblets or mini bombs are included in each of these missile things, and they are spread out over a large area, in this case over an area the size of a football field. And the explosion height can be set. This is where it gets really sinister, because they can be exposed to they can be set to explode at a particular height, which of course is where children come in. This is a picture of the ones that are being used at the moment. This is the Russian operation, and you can see that the missile goes into the area and then explodes and spreads out and covers out a very large area. And this is a report from just a few days ago where a cluster munition was recorded as hitting a hospital in Ukraine. So this is our modern world. We see aggressive, powerful regimes declaring war on smaller states or small countries for political advantage, and always the effects on children, immediate and long-term, are the worst. And it is extraordinary that we allow this to happen even in the modern era. I'll give you one example now, which has not been in the news much. I actually have a project in this area, in the region of Tigray in Ethiopia, and our project team has been completely cut off from us for over a year. The federal government of Ethiopia essentially declared war on the province of Tigray in November of 2020. It's been cut off from international news. All communications were cut, and for some reason it doesn't get on the news very much with so many other things going on. The mortality is certainly in the thousands, many thousands, but we don't have actual figures. There have been reports that starvation is being used essentially as a weapon of this war, and over 50,000 refugees are in the Sudan. This is particularly horrible for me because 40 years ago, I was living in the Sudan and looking after refugees from another war which looked very, very similar, in which the Russian-backed government of Ethiopia at that time, Mengistu Haile Mariam's essentially military government, was fighting against a number of rebel groups, and a huge number of refugees came into Sudan in the same kind of condition. So here we are 40 years later, same problem. It's, in my view, disgraceful. Nevertheless, this is the problem in Ethiopia, and it's been just simply not reported for reasons that I've already outlined. So there are other examples. And Ukraine, you see, is at the bottom of this list because we have to think of what's happened in Syria, continues, Afghanistan continues, and Yemen, the forgotten war, always the forgotten war, continues. So these are problems where, these are areas where children are on the front line in all of these areas and really and suffering a lot. I'm going to move more a little bit into the COVID, but I just want you to recognise that there is an incredible crossover between all these issues and COVID. Again, the poorest are the ones who suffer the most, and poverty and malnutrition are the issues that we're starting to see, not only with the factors that I've raised, but also with the pandemic. Incredibly, there's very little reliable data on this. I've tried to get this from the World Health Organization, and their data is so far out of date, it's hard to really make sense of it. This is a study that was done by colleagues from the Indonesian Pediatric Society, and it's in a very small area of Indonesia. You can show circled here, and it shows that during pandemic there was a substantial increase in stunting, and there was a very substantial decrease in posyandu visits, and the posyandu in Indonesia is the primary healthcare unit. So we have those two factors, and then this is the essentially the malnutrition rates in all of the various units of that particular area, and the orange bars represent the rates of malnutrition during the pandemic. And it's variable. It's not been worse in every place, but in some places it's much worse. And we have almost no data comparable to this from all of the rest of the world, where this sort of thing is almost certainly happening to the same pattern. There are more problems for children, though, with pandemic. And this is, I would say, I've called this loss of life opportunities. The school closures indicated in the map on the right, it's a little bit hard to read, but the red colours or yellow colours represent the sort of amount of time that schools have been closed. And it's interesting because the country I've just come from, Mongolia, is pictured there in green. But I believe that schools were closed there for almost a year. So I'm not sure how accurate this data are. But nevertheless, school closures has been a big feature of the pandemic. And in many countries of the world, and in many communities, school closure means people stop going to school. Children who are out of school for months usually finish up helping their parents in whatever work activity they have. And it's really only the middle class or the children of more wealthy families who get the opportunity to go back to school. So dividing the society then between those with and without an opportunity for education is a shocking consequence of pandemic. The picture on the left tells a different story. This was from a UNICEF report that came out a little while back on what's almost like an epidemic of child marriage in many parts of the world. And of course, child marriage is related to the impoverishment of parents who are essentially selling their children into child marriage circumstances. I don't need to say to this audience the consequences of that. Just a couple of other points on the loss of education. I took this data on Thailand, which is represented at the bottom. And these are, it's a little bit hard to read these data from UNESCO, but it's the number of weeks of the school of either fully or partially closed schools. The upper one is Afghanistan, and of course, the situation is much worse in Afghanistan. Not so much because of pandemic, but largely because of the appalling political situation there. Now, the consequences of school closure, we can sit here and imagine what's going to happen for children who have been pushed out of education at this in this time. But it's good to look back and see what happened in the past when something similar happened. And in 1976, in South Africa, during the struggle against apartheid, there was a school strike, which went on for a long time. And though many of those, well, a large proportion of those children, particularly in Soweto, who were on strike, never went back to school. And many of the problems with essentially young people joining gangs, becoming criminals, many of the problems that South Africa has struggled with in the decades since can be related back to this. children who are pushed out of school do not do well, and they'll not do well in the long term, and that's not good, not only for the children, but also for the society. So there's more, and I don't want to dwell on this, although I could produce actually quite a bit of data from Australia on this issue, but this is really what happens during the pandemic when there is the hospitals are taken up with COVID issues. All other things seem to be pushed to one side, and the term elective admissions is very unfortunate because many elective admissions are pretty important, and the results of those being delayed can often be fatal. This is a study from Italy. I won't go into detail of it. It basically just showed that during the pandemic, admission with a lot of critical things in children, particularly things like diabetic ketoacidosis, were dramatically reduced or delayed during the pandemic with serious consequences for children. Our next obvious one is failed immunisation, and WHO has paid a lot of attention to this. This picture is a little bit hard to look at. It's a WHO graph which highlights the first year of the pandemic, really, and it's measles vaccination, first measles dose, measles-containing vaccine number 1. And there are some striking things here, actually. During that time, in the Afro region, which is most of Africa, it's Africa not including the northern Mediterranean countries. In the Afro region, there was very little disruption in immunisation, and this is a credit to the countries concerned and to the immunisation programs that are generally pretty strong. But not all the other regions, the Americas, the EMRO, that is the Eastern Mediterranean or Middle Eastern region, the Southeast Asian region, which is really South Asia, and of course the WIPRO region, which is the Western Pacific region, all saw very dramatic declines in measles immunisation. Now, there's been some catch-up since then, but there is a substantial number of children out there who are not measles immunised. And when all of the movement of people returns to the world back to normal, we can expect to see a lot more measles. And finally, a couple of words about COVID-19, because that's what I'm supposed to be talking about. Now, the big issue with COVID-19, which Dr. Permyos has already raised, is about vaccinating children. And there's a lot of discussion about this at many levels. We've discussed this within the WHO SAGE committee, which I'm a member of, and I'll come back to the conclusions a little bit later. But it's been discussed at country level, I think, in all countries. And in Australia, I was involved in a discussion with government on this issue. There's an argument to vaccinate and there's an argument not to vaccinate. The argument to vaccinate is based on the risk of disease in children. And you've already seen some data on this, and I'll give a little bit more in a few minutes. I should point out, though, and the excellent presentation by Dr. Permyos highlighted the importance of myocarditis associated with vaccination, but there is a substantial risk of myocarditis associated with COVID-19 disease, which the American CDC presented data on, and it's clearly higher. Children as reservoirs of COVID-19, well, that has been raised. Surely there's a lot of transmission amongst children and they'll be giving it to their grandparents, was the way that people were arguing. And this was, of course, based on the flu experience. We know that this is certainly very important as far as transmission of influenza. But the argument not to vaccinate, well, people would argue that the risk of COVID in children is very small. Most cases are asymptomatic and the severe cases are mostly due to comorbidity. I'll show you some data on this in a minute. There's an argument that available vaccines should be used for those at highest risk, and those at highest risk are not children. And remember that in some parts of the world, very few people have been vaccinated at all. Just coming back to the previous presentation, there was discussion about the poor vaccination rates in Africa. Currently around, I think it's less than 10% of people in Africa have had access to COVID vaccine. And there are countries with no people vaccinated. And of course, just to remind us, I think fairly clear, that the last two serious variants of concern, that is Delta and Omicron, both arose in southern Africa and both in poorly vaccinated communities. So there's also there is data that shows that children are not major spreaders in most settings. And certain data from our country and from Europe and other places have sort of shown this, that even in schools, most of the transmission goes down, that is, goes from the teacher down to the child rather than from the child up to the teacher. But there are exceptions. And in India, there's been one very good study that showed a lot of transmission amongst children at all ages. And in residential schools, particularly in Indonesia and also in the United States, there's been a documentation of high transmission in those settings. And finally, there's a point that is also discussed at various levels, which is that COVID-19 might be useful for primary vaccination in children, after which they can be boosted with other vaccines. And that is a controversial point. So just a few things about the important periods for children. The neonatal period or the perinatal period is important. Pregnancy is an issue. Pregnant women are not at increased risk of acquiring COVID-19. They are at increased risk of serious illness and death. And so rather belatedly, in my opinion, they've been prioritised for immunisation. After birth, there are problems with how infected mothers are managed, and this varies a lot from country to country. And in a lot of settings, there is a sort of forced separation between mother and baby, which is probably not a good idea. Similarly, in many settings, especially poorer countries, there's been a huge rise in home births, and the reasons for that are obvious. And of course, home births in Africa, for example, are going to be associated with increased maternal and neonatal mortality. Having said those comments, though, there are neonatal infections that occur. There's not been a huge number. They've been written up in the literature often individually, but some of them are serious, so we can't really ignore this. And this data from Indonesia sort of highlights that, actually. This is data that was kindly provided to me by Dr. Nastiti from the Indonesian Pediatric Society, and it documents 159 child deaths that occurred in Indonesia from COVID-19. And the ages first worth looking at. There's a fair number in the first month of life in the neonatal period, but it's really only 15%. Most of the deaths are occurring in children under 5. And then there's a group that are in teenagers, and the teenagers, I would suggest, are mostly teenagers with comorbidities, behaving essentially like young adults with a risk of mortality. The most common comorbidities that were in this Indonesian series are listed there. And I think there are, I remember from the original data that there were a few others of interest, particularly tuberculosis was a comorbidity that was listed in some cases. So we can't ignore this. What about long COVID? Now, again, I think everybody knows about this condition now. It's the rather long-standing chronic symptoms that are suffered by survivors, and they're not always survivors of serious illness. Sometimes they're survivors of mild COVID. I know a couple of people who've had long COVID for almost 2 years. So we don't know really what the future is for those people in terms of their chronic illness, chronic disability. It's really associated with tiredness, fatigue, muscles, aches and pains, and in a lot of cases something that they call brain fog, which is difficulty remembering things, difficulty thinking, really. So it's not nice. And the question is, does it occur in children? And this paper from one of my colleagues in Melbourne, Nigel Curtis and his group, really summarised all the literature that was available on this and concluded that there was almost no conclusion because the quality of the studies was relatively poor, the follow-up was short, and the control groups weren't particularly good, and there's really a need for much better understanding of this. I do know of a group that's now been assembled in Indonesia and will be followed, and that's really important. And I'm sure that there are other studies like this going on around the world. But this is a key issue. You know, if 5 or even 3% of children have a long-standing illness that may even be lifelong, that's a massive incentive to vaccinate all children. And so, in my opinion, we need to understand this much better than we do at the moment. MIS-C, multisystem inflammatory syndrome in children. Just for your information, there is a MIS-A as well, which is in adults, but it's quite rare. It's also called PIMS-TS in some places like Australia, but I think in most parts of the world it's known as MIS-C. It's an acute inflammatory syndrome in children, which follows several weeks after an episode of COVID-19. It looks like Kawasaki disease with some differences, and that is it tends to be in older children, although as Dr. Permyos highlighted, it does occur in younger children as well. And it's toxic shock is a more common feature of this illness than it is in Kawasaki disease. It's not that common, and to give you an idea of how common it is, in the United States with 300 million people, up to October of last year, they had recorded 5,217 cases. So it's not that common, but it's not pleasant, and there is a mortality risk. So finally, a little bit about where we are with vaccination. I've sort of painted vaccination as being, yes or no kind of issue. Well, this is a little bit of an example of which countries have taken this on and how they've taken it on. And firstly, in Europe, this is the timeline for the Pfizer and Moderna vaccines licensure for use in children. And for children over the age of 12, both of those vaccines were licensed around the middle of 2021. There's quite a bit of data actually on the effectiveness in that group. I haven't listed it here. The key thing though is, what about children under 12? And for children 5 to 11, the Pfizer vaccine has been licensed in a dose of 10 micrograms. And this should be compared then with the adult dose of 30 micrograms. And in one study, a relatively short study in Europe, the 10 microgram dose was shown to provide 91% protection in a study of 2,000 children. So that's encouraging. The Moderna vaccine, as I said, is only licensed in Europe in older children. It's interesting to look at the coverage. And this is just coverage in older children, but it's quite variable. With UK modest 60% having the first dose. France, interestingly, which has generally been not a very good vaccinating country, has 81% of children in that age group having had 2 doses. And interestingly, a number of them are boosted, as they are in Germany. And the boosting is another question, I think, which almost requires another discussion. In the United States, 12 to 15-year-olds, as I said, the vaccine was licensed for use in 12 to 15-year-olds around the same time as in Europe. That is actually in May of 2021, the full adult dose. And then in the under 5 to 11-year-old in the US, they were licensed in October 2021. Again, the 10 microgram dose. Coverage is very poor, and in only 19% of children, according to my latest data, in the United States had been vaccinated in the youngest age group, and about 36% in the teenage age group. So their coverage is much less than in Europe. In Australia, we've very recently licensed or approved rather, I should say, the Pfizer vaccine for children over the age of 5 now. And again, a 10 microgram dose, but interestingly separated by 8 weeks. And in Moderna, just days ago, really, it was approved. That vaccine was approved for children over the age of 6. I'm not able to find very much data on that age group. So nevertheless, the responsible committee has approved that. So what do we know about the effectiveness of the vaccine in this age group? Well, especially when it comes to Omicron, not very much, of course, because Omicron's only been around for a couple of months. But this news item really just came out. I think it was. It's actually on the slide here. It's February 28, so a few days ago. And this is a news item that suggests that the Pfizer vaccine was 12% effective in children 5 to 11 against Omicron. Now, the thing I would mention here, firstly, is that it's against infection, not against disease, and that that all vaccines actually have rather limited protection against infection with Omicron. Really, the reason we vaccinate people is to protect against disease. And as the previous presentation showed you, the effectiveness against Omicron disease is still reasonable. I had to look into this to try and get the data behind it. And this is the graph that sort of summarizes the headline that I've just shown you. And the way to look at this graph is, firstly, it covers the 4 periods of January that's just passed. So it's done by calendar month, and so and this is all from New York City, so you have to imagine that Omicron is sort of entering the city, as it were. And the solid lines, each one of the solid lines represents an age group: 11, 12, 13, 14, 15, 16, 17. And you can see that modest protection in that group against infection is sort of maintained, and I would suggest that that's probably very similar to what you might get in adults. The dotted lines are representing the younger age groups from 5 to 10. And remembering that that group received a 10 microgram dose, whereas the older children above 11 received a 30 microgram dose. And so the authors of this paper conclude that this has got something to do with the dose being too low. I'm not sure about that. We have other data, particularly excellent data from Thailand, showing a 15 microgram dose in adults is quite effective. So I'm just not sure about that. But nevertheless, this is as I say, it's a preprint, so not yet peer reviewed, but it's just new information. So finally, the position of WHO in relation to vaccination of children is summarised by this slide. And of all of the slides that have been produced by WHO on this subject, this is probably the clearest. And so I apologise for that, because it's not clear at all to me. But nevertheless, I'll try and explain to you what this sort of means. The highest priority, then high priority, medium priority, and low priority are the groups that WHO feels countries should be using to decide where their priorities are. And of course, the highest priority is a mixture of people at high risk, that is older adults and immunocompromised person, and others who you really don't want to get the disease because of you want the health workers to remain in the workforce. So health workers get into the highest priority. And in this case, they should all be vaccinated. Now, if a country has a lot of vaccine availability and has good coverage, then they should be vaccinating all priority use groups. In other words, all 4 of these groups. If there is less high coverage, then they should really just be vaccinating the highest priority groups and not vaccinating the lowest priority group. And so it goes on. What they're basically saying is that your highest priority should be given to these high-risk people, then to people with comorbidities, pregnancy, and then other essential people like teachers and frontline workers. This disadvantaged socioeconomic populations, socio-demographic populations, represents minority groups. In Australia, this refers to the Indigenous Australian Aborigines. I think in other countries, there are particular groups like this who are at high risk. And then you have the medium risk of adults or children with some comorbidities. And at the very last is children. And in the fine print here at the bottom, it says, and this is true, that the booster doses in children below the age of 12 have not been assessed. And this is important because, as you saw from the previous slide at least, the risk of myocarditis, whilst it seems to be very small in this younger under 12 age group does seem to increase with dose. So we don't know what happens if you give them a third or even a fourth dose. So what can then we say about vaccination of children? Well, the argument to vaccinate children depends on in my opinion, most importantly, on the importance of long COVID in children, the risk of MIS-C and its consequences, and the safety and effectiveness of vaccination. WHO regards the vaccination of healthy children as the lowest priority. And some countries are already boosting children, as you saw from the European things. I should say as well, though, that I've spoken as if Pfizer and Moderna are the only vaccines given in children. That's not the case, and a number of countries have been giving the Chinese vaccines, Coronavac or Sinovac, and Sinopharm to children as well. But we don't have data on the effectiveness or safety in that particular group. And my looking to the future, I would say that in the post-Omicron era, most children are going to have some form of hybrid immunity. And that's the way we'll go to whatever the next one is. And there probably will be a next one. And there's no guarantee that it's going to be mild like Omicron, I'm afraid. So just to summarize all the things I've been talking about, I feel as a pediatrician, I feel depressed for all of the reasons that I've spoken about in this talk. And I'm sorry if I made people depressed. I really think that it's about time the world's leaders began to shift their focus to the future. And by that, I mean shift their focus to the needs of children, not the needs of politicians and their cronies. So I'll finish there, and I thank you very much for your attention.